Dear Mr. Chairman, ladies and gentlemen, good morning. I want to present you in the following 18 minutes a very short overview and compressed overview over the PI-RADS scoring system in terms of MRI definition of the target for MR-guided of image-guided biopsies or maybe even therapies. Why we are talking about standardization and what does it mean, PI-RADS? PI-RADS means Prostate Imaging and Reporting Archiving Data System. We have a very similar classification long time ago for breast, and it is very important also to have a standardized reporting system also for prostate. So the aim for creating PI-RADS classification was to standardize the interpretation and reporting of the various parametric MRI techniques, which allows to compare the inter-observer interpretation variability, reducing this variability on the end, enhance the communication with the clinicians in a uniform way. That is very important that everybody from the diagnostics till the therapy is talking with the same language. And of course, to facilitate the quality assurance and research, and of course the results should be better patient care and better patient outcome. It's very important to know what was as I was studying PI-RADS, it's very important to understand what was the motivation, what is the basic principle of PI-RADS. The PI-RADS classification has a lot of has a 5-point scale for every parameter, T2, DWI, and DCE. Additionally, each lesion is given an overall score to predict its chance for being significant cancer. It means PI-RADS, the overall score, PI-RADS 1, is a situation when clinical significant disease is very unlikely to present. And of course, PI-RADS 5 is clinical significant cancer is highly likely to present. We are starting with the T2. The T2 classification for PI-RADS is divided in two because the two most important parts of prostate is the transitional zone and the peripheral zone. We are starting with the peripheral zone. It's de facto normal peripheral zone without any specific changes. It's PI-RADS 1. If the changes in the peripheral zone are linear, wedge-shaped, or geographic areas of lower signal intensity, usually not well demarcated, like for example this lesion, it's PI-RADS 2. Why this is so? These criteria for T2, for DWI, or for DCE are based on idea which kind of markers I can find in image which are telling me the aggressivity of the biological properties of the tissue or of the lesion which I'm looking at. What is PI-RADS 3? It's similar like a PI-RADS classification. It means I have intermediate appearances. Very shortly say, I don't know what I'm seeing, but it should be controlled. It means, by for example, this is an area here in the left lateral peripheral zone, which is not well marginated. It could be PI-RADS 2, but on the other hand, it's no really geographical area, so it's not PI-RADS 2, so it's an intermediate appearance, it's PI-RADS 3. This is another example, which is area which is well demarcated in the right dorsolateral peripheral zone. No homogeneous low signal intensity. It is probably not PI-RADS 4. Conclusion, it's between 2 and 4, it's PI-RADS 3. But it's much more important, it's maybe to talk about the PI-RADS 4 and 5. What is PI-RADS 4? It's a lesion which is discrete, homogeneous, low signal, focus, or mass confined to the prostate. For example, this small lesion or this huge mass. This is definitely PI-RADS 4. And PI-RADS 5, it's in principle the same, which is a discrete, homogeneous, low signal intensity focus with extracapsular extension. It means the difference between PI-RADS 4 and 5 is the extracapsular extensions or invasive behavior. or mass effect on the capsule. It means bulging or broad contact with the surface. Like, for example, here with the extracapsular extension, or here, extracapsular extension in the left seminal-vesicles. It's very important in these terms to have a criteria for extracapsular extension or extraprostatic extensions, because this is the criteria which is defining the PI-RADS 5 category. First of all, is it bulging with definitely macroscopic extracapsular extension and long contact with the capsule, obliteration of the rectoprostatic angle, or only macroscopic extracapsular extension, or, like in this example, infiltration in the seminal-vesicles. Following criteria are for the transition zone. PI-RADS 1 is a classic adenomatous tissue. It means heterogeneous transition zone adenoma with well-defined margins, so-called organized chaos. Everybody who is doing prostates see it every day. This is PI-RADS 1, because the probability of these lesions to be malign, to contain significant cancer, is very, very, very low. PI-RADS 2. These are areas of more homogeneous low signal intensity, however well marginated, originating from the transitional zone or BPH nodules. For example, like that. If you are comparing this lesion with the contralateral side, you see here organized chaos. This is more homogeneous, but still well marginated. Of course, PI-RADS 3, analogous to that what I already said, it's an intermediate appearances which are not suitable for categories 1 or 2 or 4 and 5. For example, this lesion, which is well-defined margin, it's PI-RADS 2. On the other hand, some erased charcoal sign, it's PI-RADS 4. It means conclusion is PI-RADS 3. Or, for example, this lesion, which is very often with patients with huge adenomatous prostate, where we can see something like that. Organized chaos, for example, this area is definitely BPH nodule PI-RADS 1. But here in this area, some erased charcoal sign, but it's still within the nodule. It could be PI-RADS 4, but in all, conclusion is PI-RADS 3. What is PI-RADS 4 in transitional zone? It is area of more homogeneous low signal intensity and ill-defined. That's very important. It is so-called erased charcoal sign. Why it is so? Because aggressive malign tumor is infiltrating the surrounding tissue, and which is creating this typical matrix of erased charcoal sign. And PI-RADS 5 is analogous to the peripheral zone, the same as PI-RADS 4, but involving the anterior fibromuscular stroma, sometimes extending into the anterior horn of the peripheral zone, usually lenticular lesion or water drop shaped. This is very important because this is a pathognomonic configuration for aggressive cancer. For example, this lesion or this lesion. It means it's the same like PI-RADS 4, but with signs of extraprostatic, of extracapsular extension. Now, diffusion. Diffusion is maybe the most important sequence at the moment to report a multiparametric MRI of the prostate. So PI-RADS 1 is, de facto normal tissue, no reduction of ADC compared with normal glandular tissue, no increase in signal intensity on any high B value images. And the images is normal according to the ISUR criteria, should be done with B value of minimum 800 or even more. PI-RADS 2 is a diffuse hypersignal intensity on B800 image with low ADC, but no focal features. It's very important. No focal features. However, linear, triangular, or geographic features are allowed. For example, this, which is typical appearance of a prostatitis or active acute prostatitis, but not as a focal lesion. Of course, analogous to all other category 3, PI-RADS 3, also by DWI, is intermediate appearances between the categories 1 or 2 or 4 or 5. For example, this lesion, very often to find in the basal part of the prostate, in a transition to the seminal vesicles. The ADC is not that low. We are seeing some enhancing lesion in a B value, the original DWI images, but it's not really consistent, so that's why it's PI-RADS 3. PI-RADS 4, it's very important. It are focal areas of reduced ADC, but iso-intense signal intensity with high B-value images. It means by the PI-RADS classification, in the DWI images, you are comparing all the time the ADC and the original DWI. For example, this lesion is dark on ADC, but is almost iso-intense in original DWI. And PI-RADS 5 is focal area or mass of hyper signal intensity or the high B-value images with reduced ADC. Just this small lesion, you can identify it as a focal, it's a very important, focal mass of area with black and white matrix. It means black on ADC and white on DWI. Another example here in the left cranial peripheral zone on the transition to the left seminal vesicles, also mass, black and white. Another beautiful example, a ventral anterior tumor with very low ADC, a very high signal on DWI. This is PI-RADS 5. This area is a bit also intermediate appearance. You see that the signal intensity here is lower than here, but it's still as a hyperintense focal mass comparing to the left peripheral zone. So also this is PI-RADS 5. So this patient has 2 PI-RADS 5 lesions within one prostate. Now a couple of words over DCE, dynamic contrast enhanced imaging. These criteria are primarily based on the signal intensity time curves, which are very well known already for almost 20 years. So it is a type 1 curve signal intensity. It means the progressive enhancement or cumulative enhancement of the lesion. Type 2 enhancement curves is a wash-in with the following plateau. And type 3, that X is away, okay. The curve number 3 is with a wash-in, wash-out. I think this is very well known. And what we are doing with that, there are 2 additional points. If the lesion which we are looking at in the DCE is focal, we are adding another point. Or for asymmetric lesion or lesion in unusual place, if these lesions are already showing curve number 2 of type 2 or type 3, we are adding an additional point. How does it work? A couple of examples. For example, DCE PI-RADS 3. It's a color map of K-trans, of KIP. You are seeing this popcorn enhancement, which is typical for benign prostatic hyperplasia, which is non-focal because it's on both sides of the transitional zone. It's not asymmetric, it's symmetric on both sides. Curve number 3, so the final PI-RADS for this category, it's PI-RADS 3. Another example, it's PI-RADS 4. Why? Because it's curve number 3, but it's a focal enhancing lesion. I do not really see any other comparable lesion in the transitional zone. So it's in this case, additional 1 point, it's PI-RADS 4. And PI-RADS 5, it's this small lesion, it's curve number 3, it's focal. I can identify it on the images in a DCE as a focal lesion. And as a, of course, asymmetric lesion on unusual place. It's also unusual place normally if you have adenomatous tissue, you can have these curves in the transitional zone, but in peripheral zone are definitely not common. this is pathologic. That's why it's type 3 curve plus 2 additional points, it's PI-RADS 5. So, now the overall interpretation. You are now scoring for each sequence which are using T2, DWI, DCE. And now the question is, what is the final PI-RADS score? What is your final judgment over the lesions? There were a lot of discussions about it in the last year, and we are convinced that the final PI-RADS score is not the sum score. So you are not adding all these points for each lesion, but rather an overall interpretation score. What does it mean? If you are saying PI-RADS 5 is in all three sequences, you are saying, okay, that's 5. PI-RADS 5 for T2, PI-RADS 5 for DWI, and for DCE, it's surely an aggressive cancer. So the final PI-RADS is 5. If not all are consistent, we are using the principle of so-called dominant sequence. It means that if you have a lesion in a T2, in a transitional zone, the T2 sequence is the dominant sequence. So in case of inconsistency, you are using the rule of dominant sequence. So what you are looking at a T2, that's your PI-RADS score if you are talking about a lesion in a transitional zone. If we are looking at a lesion in a peripheral zone, the DWI score is dominant for peripheral zone. There are a couple of publications about it, about a correlation between the ADC and the aggressiveness of the lesion in the peripheral zone. It doesn't fit, unfortunately, not that good with transitional zone. And in case of recurrent cancer, the DCE is probably the best dominant sequence to find a recurrent cancer in a case of after prostatectomy or radiation therapy. There are also some publications newly published that also diffusion can show something. This issue is not discussed yet to the end. I think at the moment the DCE is still the dominant sequence for recurrent cancer. So once again, if you have 5 in all three sequences, it's surely PI-RADS 5, it's okay. If you have some inconsistency, you have to use the rule of dominant sequences. And how does it fit with MR-guided biopsy or interventions? There are a couple of basic principles. Of course, we are making diagnostics on treat the patient and make a good diagnosis. So all lesions, PI-RADS 4 and 5, have to be biopsied. And exception also PI-RADS 3, especially patients with very difficult prostate. It means patients with chronic prostatitis after 3, 4, 5, 6, 7, 8 TRUST-guided biopsies with a lot of chronic prostatitis where you cannot use the criteria of PI-RADS very well because of a lot of changes. So you have a lot of PI-RADS 3 lesions. If you have very strong clinical suspicion, you can also recommend biopsy of PI-RADS 3 lesion. It's okay. In this term, it's very important to say the quality control, if you are using multiparametric MRI, should be correlated with results of MR-guided biopsy or prostatectomy or both. Normally, we just started with PI-RADS classification 1.5 years ago. If you have over 85% of correlation of PI-RADS 5 lesion versus prostatectomy or results in MR-guided biopsy, this is a good start. Conclusions. PI-RADS classification reflects the biological properties of the tissues or the lesions which you are looking at. And therefore, it's suitable for biopsy target definition because you want to biopsy the most aggressive part of the tumor, and PI-RADS is reflecting this issue. And of course, PI-RADS interobservable variability needs still to be determined. We just started, and further refining of the PI-RADS is necessary. Thank you very much.